Hello everyone. Congratulations on finding this room. The challenges of commissioning will be but nothing once you've discovered this room. My name's Alastair McLellan. I'm the editor of the Health Service Journal. Welcome to Addressing the Asthma Challenge in the New Commissioning Environment. I go to lots of events and chair and speak at lots of events which talk about the macro challenges around the changes that we've seen in commissioning over the last few years. I think, especially now, those conversations are more interesting when you look at this micro aspect of a particular area of care, service line or whatever like that, because I think that really brings out some of the opportunities and some of the tensions in the new system. So we're going to hear an opening contribution from our four panellists. Charles is being pulled away to an important meeting, but he will promise to join us before the end of the event if he possibly can. After we've heard from our four speakers, I'm going to ask them some questions, but very quickly I am going to open it up so that you can ask them some questions. So please be prepared to contribute, because I think that will much improve the event. Can I remind everyone to put their phones on silent, please? Don't turn them off, of course, if you plan to tweet. I don't think there's a hashtag for this. There isn't a hashtag for this particular event, so I assume I will be using just the standard ComShow hashtag. I won't be texting, by the way. Here, I will be tweeting, just so that everyone knows, doesn't think I'm multitasking in the way that I shouldn't as the chair. Right. Okay. So let's move on. We're going to hear from our first speaker, who's Kevin Holton, who is Transition Lead for Diagnostics, Science and Early Diagnosis at NHS England. Kevin, take us away.
Thank you very much. I'd just like to regale a story, actually, because I was the policy lead in the department for a number of clinical conditions, including respiratory disease, before I went to NHS England. And I remember going to an event in Liverpool, because we held a series of patient events. And we were about halfway through the event, and these two twins turned up to the event, and so I went over to them and asked how I could help. And one of them was carrying a brown bag, so I said, how can we help? And she said, well, I've just been to the doctor, and I've just been given this thing in this brown bag, and I don't know what to do with it. I don't know what I've got, because the doctor didn't really explain. I heard on the radio that you were running a patient event about respiratory disease, so I thought I'd come along and see if there was someone there who could explain to me what was in the bag and also what was wrong with me. So I got one of the consultants who was helping run the event to come and talk to them, and it transpired that she'd been diagnosed with asthma. She had an inhaler in the bag, but nobody had told her about what the condition meant and also how to use the inhaler and actually what the inhaler was for. And I think that was a particular challenge for me, and something that we were focusing on chronic obstructive pulmonary disease. It made me, I think, want to focus on asthma. I think that there is a case for asthma. The prevalence is around 10% of the population. It costs around £1 billion a year for the NHS. For children, asthma is the most common long-term medical condition, and it affects about 1.1 million children. And I think that one of the issues I think we're going to discuss today is about variation and whether that matters. You see about a twofold variation in prevalence. Exception reporting from QOF for the annual review varies between 0 and 50%, interestingly, when you look at GP practice data. There's about a 5-fold variation in asthma admissions for children and about a 6-fold variation in emergency admissions for adults with asthma. And I think there's a number of reasons for this. I think, firstly, the NHS is non-compliant with evidence-based guidelines. It always surprises me when I talk to patients, and when we held these patient events, the question we asked at the beginning of the event was, are you happy with the service you receive from your healthcare professional? And predominantly people said yes. We then described what a good evidence-based service looked like, and then at the end of the session we said, do you receive this service? And the vast majority of people said no, they don't receive that service. So there is something about picking up evidence-based guidelines. Generally, there isn't a systematic approach to commissioning services from kind of end to end, so from primary care to acute sector back to primary care, and also utilising a whole range of other healthcare professionals like pharmacists and other people who come into contact with patients. I think some areas don't systematically review their patient population, and you look at figures, around 5% of people with asthma use about 80% of resources. Inadequate training of people who are taking diagnostic tests in teaching inhaler technique, and I think maybe local reason around deprivation, air pollution, local industries. Does it matter that there's a variation? Yes, I think it does matter for people with asthma regarding quality of life, and also for the NHS in wasting resources. I was asked to kind of explore what lessons could learn from the respiratory environment. I think that using data to drive change is one thing that we've learned. The importance of following evidence-based guidelines, as I said. Proper clinical engagement, I think, is key across primary and secondary care, and link up with other healthcare professionals. And also you need healthcare professionals to actually buy into what it is that's being commissioned. I think training people to undertake the services that they're delivering, and also a need to review the financial flows that exist. I think that how can we achieve better clinical and commissioning services? By analysing and benchmarking data, by developing evidence-based pathways, by using levers available around things like sequins and quality premiums, and most importantly, and something I learned in the department very early on, was by engaging with patients and carers.
Thank you very much. Right, fresh from being named one of the top 10 clinical leaders in the country on Tuesday night, our next speaker, Dr. Michael Dixon.
Thank you very much, Alastair. And I'm going to speak from the point of view of the new clinical commissioners and reiterate very much of what you've already said, actually. Because I think the first challenge for all of us as commissioners is going to be that issue of getting the right data, knowing exactly how you're doing already. Where are the inequalities in your area? And moreover, it needs to be benchmarked. We need to be able to compare how we're doing in our CCG with other CCGs, particularly if they're matched CCGs, a rural with a rural, an urban with an urban, and also be able to look channel down so that no one can hide, down to the individual GP and practice to see exactly how they're doing and hospital. So first of all, we need the data, the evidence, and we need a lot of patient feedback in that, from a patient perspective within it. Then, having got the data, we need to start looking at where are the challenges and weaknesses, where are the biggest bangs for our bucks. Is it in improving specialist nurses in general practice, or is it in improving the care of our most brittle asthmatics who are going in and out of hospital? Then we need to get a strategy going, and now I think we can be a bit revolutionary in this. We can actually have primary and secondary care planning the strategy within a clinical commissioning group, and looking exactly at who does what, and making sure that patients don't fall in the gaps between the paving stones. And it seems to me that clinical commissioning groups, especially working with their health and wellbeing boards, can be far more integrated than ever before, not only looking at primary and secondary care, but also social care, but also education, also housing, leaking roofs, wet walls and the rest of it, and making sure that we've got a really decent integrated approach to treating asthma and preventing exacerbations. And then the final challenge, I think, is going to be how we get this funding between primary and secondary care right. I've just been bellyaching in the national auditorium about the fact that the funding has continuously gone from secondary to primary care. The amount of funding for general practice as a proportion of the NHS has gone from 10% 5 years ago to 8% today. The Nuffield Trust showed that 1.4% more went to secondary care last year, 1.4% less to general practice. Well, you can't do more in general practice and primary care unless you've got the resources, particularly the specialist nurses, to do that. So The next question I'm going to ask is, how do we improve the standards? And I'm just going to throw out a few ideas here. I think, first of all, we need to get self-management plans for every asthmatic, so every asthmatic knows what they're doing, and also, yes, exactly how to do it. I have to say, I send my patients now to pharmacists to learn how to use their volumatics and inhalers, because too often they haven't got them when they're with me, but they'll always have them with the pharmacist because they're collecting them from them. I think every practice should have an at-risk register for the brittle asthmatics, because we know that they take up 50% of the costs, even though they're only something like 5% of the population. And if you want me to be radical, I would suggest that we should in future consider the admission of every asthmatic to hospital as a significant event, on the basis that those admissions apparently are 75% preventable, and also cost £60 million a year. But forget that. Just start thinking about the 1,000 people that die a year. If we really look seriously at every admission, I think we begin to start chopping away at that as well, because we begin to see what were the factors that led to that admission that stopped us heading it off at the pass. I've been asked to say, is there a place for innovation? I'd say categorically yes, but I think innovation too often means imposition of nice guidelines and whatever bits of paper are filtering down from wherever. I regard innovation as listening to your patients and local patient population, your patient participation groups, listening to what your supermarket chief executives are saying, and working with the local authority and getting a local plan that is fit for purpose, dependent upon your geography, and I should add weather conditions, which, as we know, are incredibly important in asthma as well. And then finally, the question I was asked is, how will commissioners bring about change? Well, I think, first of all, the new clinical commissioners will make sure that we get better value for money, so we've got more money to do the right thing. I think, as I've said, we'll bring down the death rates, because if we're looking at every hospital admission, trying to save the money from that and trying to save the patients from getting to hospital, that will have a direct dent on the death rates. I hope we'll improve the quality of life of our patients. And as generalists now commissioning, we're going to have to look very much at comorbid commissioning. We know that in the over 65s, the average patient has 2 or 3 different conditions, so it may be asthma, heart disease and osteoporosis, and we need to start commissioning a little bit more cleverly, going across the boundaries and not just looking at one disease at a time.
Thank you very much, Michael. Right, our third speaker, who's Andrew Roberts, who's Director of Market Access and Communications for Napp.
Morning, everybody. I always manage to hide the horns and the spiky tail in events like this, because whenever there's an industry member on the panel, there's always a sense of, well, what are the industry going to say that we haven't heard before? I always find events like this about asthma interesting, because I've got 3 very big, strapping, healthy kids who were all very brittle asthmatics from birth. So as well as having worked around respiratory for most of my career in pharma, I've always had that in the background, so I've always kind of worn 2 hats, both from an anxious parent who spent many nights in A&E or sleeping next to beds in paediatrics with wheezy kids. But you know, we are an organisation that are involved in respiratory, and like all parts of the industry involved in respiratory currently, you know, we're getting asked to help muck in and do things to support commissioning, and a lot of what's been said so far I would completely agree with. And in fact, being around the event, there's an awful lot happening around best practice in commissioning that can be applied to asthma. And we were just talking before the event started about this, that actually if you put all of the best practice that people talk about at events like this and put it in a hopper, you know, and what comes out the other end would be something that would probably fix a high percentage of the issues we're seeing. But it's how do you get that granularity and how do you get that best practice moving? And that's a big agenda for our industry, and I don't just speak about my organisation, I speak about most other companies that are involved in respiratory. And I think probably like a lot of you, when the 1st of April came, you know, we were quite apprehensive about what that meant for the pharmaceutical industry, because there was a big message going out from the centre about collaboration, about partnership, and you know, and the phone did take a long time to ring, but it is now starting to ring more and more. Our starting point at Napp is to really ask a simple question, and that is, you know, where do we where do we share the same values? You know, where do we overlap? And that's got to be our common ground. Probably many of you are thinking that historically the industry doesn't have a great track record, and we do have a few failures in the background that we need to move on from. But I can speak from everybody working at Napp. Our primary focus is outcomes for patients. We know that our medicines will only be valued and be used going forward if they deliver robust outcomes that can be measured and therefore extended and expanded into other patients. If we can't provide that data, then it's going to be more difficult for us to maintain our medicines use within the NHS. So, you know, what sort of things are we doing aligned to that? We picked up some months ago now on a program that was running very successfully in the Isle of Wight about inhaler technique. And we looked at some of the evidence that came from that project, and we found that it led to around a 75% reduction in admissions to hospital, which we thought was a significant figure. And you know, one of the simple things that we feel we can get more involved in is looking at inhaler education, how patients use their inhaler. You know, what Kevin highlighted at the start resonated. You do genuinely still get patients who leave pharmacies not knowing how to use their medicines. They may have been instructed in the pharmacy how to use their medicines, and that might be a very high quality discussion. But patients forget, as I'm sure many of you are aware, when they get home, they might not be aware of how to use their medicines correctly. And I think that's a big area for our industry. How can we ensure that patients are able to use their medicines effectively and get the most from the investment that the NHS are making in that medicine? And I can speak from our organisation, that's very much on our agenda currently. Coming back into respiratory, we know that this is an area of need. So, not surprisingly, we're looking at taking that best practice that's come out of the Isle of Wight, and we're looking at how we can extend that into simple inhaler education programs that we will make available across the UK to those that approach us. One of the other areas, in fact, that we've become more involved in recently, we were approached by NHS England in the east of England, their Prescrip programme. And we currently have somebody seconded into that programme at the moment, looking at sharing best practice. It's very much an MUR-based programme, focusing on patient education. But in particular, it's a project that looks at transfer of care. So it's a programme running in the east of England where, as patients are discharged from hospital, having presented to hospital often through A&E with unstable asthma, it's how those patients are managed, and they're managed by pharmacists in the community to ensure that they're using their medicines correctly, they're following the guidance they were given in hospital, so that on discharge they're less likely to re-present. We don't have any evidence from that project yet, but that's something we'll be publishing. But where we have limited resources as a company, that's the kind of area that we're looking to put investment in. It's very much around education, directly at patients, but also at healthcare professionals. The other area, we also have something called Napp Academy, which has been running for many years in pain. Our history is within pain and analgesia. But we learnt a lot from what could be done there in helping the NHS educate patients more effectively. And we've extended that now into respiratory. So we have programs running under the Napp Academy that maybe plug a hole that's been left where training budgets have been cut. So it is an educational program. It's a service to medicine. It's not linked to our commercial arm. But the results we see from that do actually get transferred across through to patient care. And finally, one other area I just wanted to highlight, we are acutely aware of the importance of understanding outcomes from medicines, and there's a lot of talk now about real-world data capture. So what actually happens with our medicines to patients in the real world. That's data that maybe appears outside of the traditional RCT, and we're investing heavily at the moment in audit to ensure that any patient that's put on one of our newer medicines is tracked. It's not a requirement, it's something there that's available through the organisation, but if any of you put a patient onto one of our respiratory drugs, then you have the option of auditing and tracking that patient to see what happens to them going forward. We're capturing that as anonymised data because we want to know what happens to patients that are initiated on any of our medicines, and we're also starting to do it with our pain portfolio. So that's a big part of our ethos going forward. You know, there's been a lot of questions asked of pharma, how do you provide data on your medicines and how they're working? And we've started to do that now, and we will make that data available to you in respiratory. And it can be linked to other programs, educational programs that localities are using. As commissioning improves, you know, we can work with organisations to track the outcomes from those patients through those different service arrangements. That's all I was going to say.
Thank you very much.